Good afternoon. I hope you had a good lunch and you enjoyed. Thank you very much for coming back on time. My talk in this presentation will be on comparator products and reference products. How we can select the appropriate reference comparator product and what to do in case of changes. More or less, since 20 years, my company dealing with the reference as reference provider to pharmaceutical industry in Turkey and surrounding countries. For that reason, I am taking my experience during this period to you. And the outline will be introduction, comparator reference product related definitions, review of reference comparator product in the guidance documents, how and where comparator product can be identified, comparator lists by some authorities, how the comparator product should be selected, some experience on comparator related issues, and information on comparator product be included into the dossier, application dossier. Let's talk a little bit about the comparator reference products. Selection of an appropriate comparator reference product is an important part of the bioequivalence studies. Additionally, formulation development studies. Comparator products should be the product that were shown to be safe and efficacious in the pivotal clinical trials to ensure prescribability of generics. The use of a common comparator reference product ensures switchability between generics. The selection of the comparator product is a national responsibility and may be different between the countries. Most countries follow the Orange Book of FDA and or some other regulatory authorities' advices and World Health Organization recommendations for selecting comparator or reference products. Some of the countries require the comparator product to be obtained from their national markets to ensure switchability between the local comparator and their generics. These recommendations are only feasible in a few countries where the repetition of the bioequivalence study is economically feasible, but they are impractical in all other countries. It should not be forgotten that the exclusive use of the local comparator to ensure switchability is ethically and scientifically questionable. The innovator product from well-regulated markets should be the global comparator product. This harmonization is feasible as the concept already applies in the WHO pre-qualification program. It is ineffectual to harmonize only the requirements for performing bioequivalence studies. If such a study has to be repeated for every single country, simply because of the different comparator products, then the problem starts. Before continuing to comparator product issue, I would like to give you some adapter categories: product life cycle and adoption issue. As all we know, the new drugs comes from the innovator companies. You can see here, this part is the innovator company's part, and of course taking a lot of time, but when we compare with the others, we can understand the life cycle here, product life cycle here. And the second part is early adapter part. And third part, early majority. And the fourth part is the late majority and the laggards. If you think about this schematic presentation, you can put the companies in different parts. It means this approach related with the creativity, innovation approach, and the fast track approach of the companies for the new, although generic product. There is a strong relationship between the product adoption process and the product life cycle. This would, in the initial stages, connect directly to the introduction stage of the product life cycle. In this stage, firms are primarily dependent upon consumer known as innovators. And here we can see the different interpretation. Customers want technology and performance. Innovator companies' product and the early adapters, generics. Customers want solution and convenience. Then early majority, pragmatist group. Late majority, conservative group. And the laggards, skeptics. And if we interpret under this scheme, we can put our companies in one of them. And to make the money in generic business, this approach, early approach, is much more important than the other ones. You can see here characteristics of pharma companies from innovator to laggards. And I think somewhere in this slide, the comparator products having very important place. Because if your approach is only for your country's market, you can use an internal comparator product. But if your product really is an attractive product, and some other countries, companies can approach you and ask to register your product in their country. But because of comparator product, it will be difficult to register it if it is not real brand name comparator product. And all we know, multi-source product, therapeutical equivalent and therapeutic equivalence and interchangeability is very important. And here, pharmaceutical equivalent product, reference and test, we should go on that way. Possible differences, drug particle size, excipients, manufacturing process, equipment, site of manufacture, and batch sizes. These are the parameters affecting the test product's performance. For that reason, we know it is not possible 100% to have reference in our formulation. because of, let's say, particle size, because of manufacturing side differences. For that reason, it is not very important to be 100% same, but the outcome is very important. The first step is pharmaceutical equivalence. And then we can go documented by equivalence, therapeutic equivalence, and if our product will be the good one after all steps, then we will have a chance to go to the market. I will not give them in detail. As you know, since many years we are dealing with bioavailability, bioequivalence. Just to remind you, comparator product or reference product, the bioavailability and bioequivalence issues are very important. Let's take a look at the other part. Comparator or reference product is an innovator product. This is the first thing. The comparator and reference product will normally be the innovator product for which efficacy, safety, and quality have been established. The comparator product is a pharmaceutical product with which the multi-source product is intended to be interchangeable in clinical practice. Generic product and test product, or test product. Generic product is a pharmaceutical product usually intended to be interchangeable with the innovator product, marketed after expiry of the patent or other exclusivity right. Okay, let me come to the first target to select the reference product. A reference listed drug is an approved drug product in oral, to which new generic versions are compared to show that they are bioequivalent. A drug company seeking approval to market a generic equivalent must refer to the reference listed drug in its abbreviated new drug application. EMA, European Union Medicine Agency, do not have a list like Orange, but we can find in different documents what we are looking for the comparator products. Let me return to FDA Orange Book. If you would like to search one of your active pharmaceutical ingredient as a drug product exists or not in the United States, you should go to the FDA Orange Book page. If you take a look here, you can search by applicant as company name. You can search by dosage form as tablet, for example. You can search by route of administration, oral way, for example. Here, you can see ibuprofen. When I checked yesterday evening, there was 283 products on the Orange Book list. I'm sorry, they are a bit blue, you are not able to read, but that part, there is not ibuprofen single active pharmaceutical ingredient as single ingredient. These are combinations. If we continue the other page, we can see the ibuprofen single tablet comes from the others. But in this list, two important things for the searching person. One of them, reference listed product. The other one, reference substance. We should look first reference listed product, or tablet, or capsule, whatever you are looking for. In that point, I should mention another thing. All product on the Orange Book, which can be used reference list may not be exist on Europe. But if the big pharma companies, if the product in the United States, a big pharma company's product, you should review very carefully European side or the other part of the world. You may reach somewhere. Contacting with the agency, you may claim this product can be utilized as comparator product. But these are not high as percentage, but sometimes because of the off-patent period, the big pharma companies thinking that some of their products are not profitable and they are selling to other companies. In that case, there are two issues can be faced. One of them, the companies selling without selling the brand name or with the brand name. To find the product on the literature can be easy with the brand name, but sometimes the new company using the same formulation but under another name. In that case, you must go detail in the internet. You should search the law side when the company sold this product to a new company, and you should find in the detail, is there any name transfer or not? If there is not, you can copy and present to your authority, saying that, look, this is the reference product, but sold to another company. They are manufacturing in their side. It's a different case. But sometimes the big pharma selling and saying that I'm the top manufacturer, I can manufacture your product. It means in the same manufacturing site, in the same facility, then the product can be utilized even under another name as the reference product. You can get some detailed information, human veterinary and herbal medicines in Orange Book. Also, we can have some information from the European guideline, 2010 guideline on bioequivalence, and Article 10.1, 10.3, market authorization application reference must be made to the dossier of a reference medicine product for which a marketing authorization is or has been granted in the European Union on the basis of a complete dossier, in accordance with the Article 8.3, 10A, 10B, 10C of Directive 2001/83/EC as amended. Let's come to WHO. WHO also has an approach, harmonization for the comparator products. That's why they have a guidance on the selection of comparator pharmaceutical products for equivalence assessment of interchangeable multi-source products. WHO Expert Committee on Specification for Pharmaceutical Preparations, 49 report, 2015, Annex 8, giving detailed information. You can go and you can see in detail. Comparator list by some authorities. WHO, as I mentioned, choosing comparator product from the comparator list. For WRC, choosing innovator product from the well-regulated countries, ICH and others. No innovator comparator reference product. If no innovator comparator is available, a generic market leader can be chosen within the country. Comparator products should be obtained from a well-regulated market, as I mentioned before, with stringent regulatory authority related to ICH issue. Again, countries officially participating in ICH are the ICH member, the target member, European Union, Japan, and USA. In the ICH observers, Canada and Switzerland. All these countries have different approach to help the industry for the comparator products. And you can see here the WHO Expert Committee Specification Published Preparations book, and you can use it for this purpose. In detail, WHO guidance on the selection of comparator pharmaceutical products for bioequivalence, for equivalence, also can be seen in the Annex 11. And a pre-qualification program of WHO provide some information in this respect. And you can search on the pre-qualification program your API reach. If you are not able to reach the information, what I said previously, you should go to UK MHRA page and search the public assessment report for what you are looking for. Let's say atorvastatin. You can enter the internet saying atorvastatin public assessment report UK MHRA. If MHRA got an application for a generic product, internally they are preparing a public assessment report. In this report, if you read first 2-3 pages, you will find certainly the brand name of the product. Then you can use this product as reference product. I gave here an example, lacosamid belonged to McDowell company, and when I entered this public assessment report, I found the reference product name. You can see here, I made yellow. In the United States, reference standard is the drug product selected by FDA that an applicant seeking approval of an ANDA must use in conducting an in vivo bioequivalence study required for approval. Okay. In some instances, the reference listed drug and reference standard may be different. You should notice that one, but the first target is reference listed drug column. You should use it. Some of them can have without reference listed drug information, directly reference standard the reference standard information. How to reference product should be selected? Let's give some other information. In some instances, when FDA has not designated a listed drug as a reference listed drug, such listed drug may be shielded from generic competition. If FDA has not designated a reference listed drug for a drug product, the applicant intends to duplicate, the potential applicant may submit a control correspondence to the Office of Generic Drug to ask FDA to designate a reference listed drug for that product, drug product. And there are some information like in detail in the FDA page. And let me come to the some experience on comparator related issues. These examples, selected examples, was brought by Dr. Delling, and I'm giving this information to you. And erysidone, the first selection, erysidex. This information coming from Brazilian, okay? And teribalidin was included at the same time under the name of teribalidin, included in South America's national tuberculosis control program. In Brazil, it looks like as a generic on the market. And it's a question mark to us. Should we use or not? But after reviewing, is there any other chance, we can find this South African National Tuberculosis Control Program and the teribalidin coming from Sanofi. If you search Sanofi's information, probably you may reach the detailed information which can give us chance to be used this product as innovative product or reference product. You can find the detail of erysidone here with the general items, but I will not go in detail. You can reach this page in the related web page. Sometime wrong comparator from ICH countries. But the wrong comparator, what does it mean? We can see here Centrafar, the product company. Product information, pyrozinamide tablet, 500 milligram. Choice justification, national market leader. But if you made this selection from an ICH country just for national market leader, you may not be right, because this is not the brand name. It's just national market leader. For that reason, it must not be used as the reference product. Here, comparator from non-ICH country. Again, microgenome, Turkey. The comparator product was collected by hand of Araba Pharmacy, Doha, Qatar. This is discussed. It's necessary to discuss on this kind of situations. Why?
Dr. Hinkle?
Yeah, I'm finishing. I'm finishing. Because some countries may not have manufacturing facilities belong to the country, and by the agency permission, they may import from outside, from an acceptable country. In that case, this information is not enough. At the end of my talk, I will show you what must be done. And unclear from which country. You can see here, the comparator product was bought in a US pharmacy by a relative and carried in his luggage to India. This is also not a clear situation. There is one exception, I will come at the end. Another one, two foreign reference products can be used, taken from different countries, test product. And you can see two reference products giving different results in the dissolution studies. For that reason, first, before starting the studies, every company must run at least 3 different manufacturing sites belong to the same company, and which one, this is not scientific knowledge, of course, logically, can make the closest one to your results for bioequivalence studies. But this is not the scientific way, I should mention that. And now, some of the examples were not accepted. Why? First of all, if you are buying for your company reference product from outside of the country, where you are going to buy, why you are buying the product, you must get the information on a document and signature of the pharmacy or wholesaling pharmacy company. For example, specifications for the requested product, name of the product, name of the active substance, country of origin, and company, form, strength, quantity, batch number, expiry date. Minimum 1.5 year expiry date should be before, you should pay attention before buying the product. And product directly sent to your company or giving to someone. Shipment delivery information, the company must put their stamp and signature. Invoice directly sent to the company, for example. And here, document stating where the product is purchased from. More or less same information, and the date, signature of the pharmacist, and stamp of pharmacy.
Doctor,
this is the form. The last slide. I will not go that one. You can use this as the decision tree for the comparator product. This what's the name? Yeah. Conclusion. Okay. The innovator product from well-regulated markets should be the global comparator. This harmonization is visible as the concept already applies in WHO Critical Application Program. It is effectual to harmonize only the requirement for performing bioequivalence studies if such a study has to be repeated for every single country simply because of the different comparator products. Thank you very much for your attention.
Thank you, Dr. Mukhtar. Very important and comprehensive presentation. We may have just one question. We don't have time. There's any question? Thank you, Doctor, for your presentation. If we want to repeat the BE study after post-marketing of the product, how can we select our reference product? How can we select our reference product? And how we can evaluate that the BE study is passing or fail? Even without changes or something like that. Yes, post-marketing. Yes.
Can you repeat your question once more, please?
If we repeat the BE study after the product is in the market, how can we choose our reference product? We did the BE study before 10 years, and after 10 years we need to repeat the BE study. We are depending on reference product before 10 years, even from our market or from European market or whatever global markets we choose. If we want to repeat the BE study, how can we choose the reference product?
Well, frankly, to a certain extent, you are right. Until 10, 15 years ago, if you remember, the mergers started between the pharma companies. And even big pharmas started to merge with each other. And what happened then? On Europe, for example, the big pharma A had 10 countries manufacturing something. When we start to work different countries, same companies manufacturing outcome, the solution was completely different from one to the other. They also know this point. They started to merge internally the facilities. They closed some of them, and they started to use one or two. And for that reason, if you remember, CTD issue started in 1990s, the end of 1990s. The new process came in the registration phases, like variations. Earlier time, I worked in Turkish ministry commissions many years. And believe me, when I entered 3 years, first year, when I opened the dossier, there was more than 10, 20 different formulations. We were confusing which one is the last one. This is your question. And after CTD is finished, because the variations completely under the control of the health authority. For that reason, what you are looking for as comparative product from the market within last 1 year, for example, you will reach the last variation formulation. If it is formulation related, then your product, comparative product, will give you the best.
Our next speaker is Dr. Yazid Al-Musayya. Dr. Yazid is Assistant Professor of Health Policy and Pharmacoeconomic Research Coordinator of the Pharmacoeconomic Unit, Supervisor of the Pharmacy Education Unit. Dr. Yazid will talk about the prospect of establishing a solitary version of the United States with drug application Orange Book and its potential implication on the pharmaceutical market. Dr. Yazid, you have the mic now.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, before I get started, I'd like to thank the organizing committee for their generous hospitality. Honestly, I don't consider myself a foreigner here in Jordan. However, I consider myself a foreigner to the bioequivalence and pharmacokinetic area. So I'm not going to be talking about the bioequivalence and pharmacokinetics aspects of it, or the technicality aspect. What I'm going to be talking about is the prospect of establishing an Orange Book in Saudi Arabia from a health outcome and economic outcome as well in the market. I'm sure that you are concerned about the bioequivalence testing, but I think most of you concerned most about what happens aftermath once the medication gets registered and launched in the market. So there's an outcome, market with withdrawal from the market or recall, or patient safety or adverse events or clinical outcome issue, that will be more concerning to most of you, I think. So I'm sure also I'm not going to be this person to talk about the to talk about the Orange Book. I'm sure we have some expert here from US FDA. But it's good to have, refreshing, summary about what's the Orange Book about. Thanks to Dr. Hanikos, but he actually made it easier for me to talk about it. So, without further ado, we, in the Saudi discussion group of the American Association of Pharmaceutical Scientists, which was established a year ago, exactly a year ago, we thought about, having a meeting to discuss the prospects of Orange Book in Saudi Arabia. And this didn't come out of the blue. We hear a lot of rumors in the corridors of the Saudi FDA. We're in touch with most of, I would say most of them, in the academic corridor. Then there are some issues with, having a reference about the therapeutic substitutability or interchangeability. But we'd like to know more about it. So the Saudi discussion group consists of academicians, regulators, industry people, and we'd like to have a meeting to discuss the prospects of establishing a Saudi version of the US FDA Orange Book and its potential application on the market, as well as on the patient safety. So I'd like to take off the hat of being an industry person to think about a clinician, because I receive a lot actually of concerns from multiple prescribers about the quality of generic medications. I know many of these claims are not well-founded, but some of them do. So, yeah, here you go. So, disclaimer, the overview, the views of and opinions, sorry, I think I'm not used to that pointer. All right, here you go. So, the views and opinions expressed in this presentation are those of the presenter, who's me, and not necessarily represent potential future official policy or position of any individual other than the presenter. So, this is a disclaimer from the get-go. Okay. All right. So my objectives for today's presentation is to give you an overview about the US FDA Orange Book, which Professor Hanickel has done, thanks to him, and discuss the agenda of a recently held scientific meeting about the prospects of establishing a Saudi version of the US FDA that was held 4 months ago, and we had another meeting a month ago in the Saudi FDA about the same topic. So this is going around. I'm not sure if it's going to be established or not, but there are a lot of rumors going on. What guide is used for generic drugs? So we had discussed the following points. What guide is used for generic drug substitution in the Kingdom of Saudi Arabia? Were there any issues of therapeutic inequivalency in the past? How did these incidents impact the public health? And what role the Saudi version of the US FDA Orange Book may play in ensuring patient safety? Will the rating of different generic drugs based on their therapeutic equivalency affect their prices? All right. So the FDA approval process is well known to most of you, if not all. The standards established by the US FDA for approval of prescription and generic medications can be found under the Drug Price Competition and Patent Restoration Act, also known as Hatch-Waxman Act of 1984, which made it possible for generic medication manufacturers to apply for abbreviated new drug application and get in the market without the problems of going through clinical trials. All right. Any approved generic product must be therapeutically equivalent to the reference innovator drug, and it has to be approved to be safe and efficacious, and therefore bioequivalent, and manufactured according to the GMP or good manufacturing practice. All right. So how about the pharmaceutical equivalency? Any generic medication should contain the identical amounts of the same active ingredients available in the same dosage form and mode of administration, and meet the compendia for strength, quality, purity, and identity. Can generic medication be different from the innovator? I don't need to talk about this. Professor Hanickel has already touched upon that in his previous presentation. Last presentation. So what is bioequivalence? I am not an expert in that. You guys are experts. You can teach me about it. But we had given the attendees or the participants an overview of what bioequivalence is. And that's what we have given them before we start the discussion. So the FDA defines the bioequivalence as the absence of any significant difference in the rate and extent to which the active ingredient and the pharmaceutical equivalents become available at the site of drug action or bioavailability when administered at the same molar dose under similar conditions in appropriately designed studies. So we have 12 to 36 healthy volunteers, could be single dose, crossover, or multi-dose steady state, administered highest strength of generic innovator drug, and then they measure blood concentration to determine maximum blood concentration Cmax in the total area under the care, also known as AUC. So the use of FDA bioequivalence limits, and these are also applied in Saudi Arabia, to the best of my knowledge. They have to be, the AUC and Cmax have to be between 85% and 125%. And there has to be, they have to fall between, that range in a 90% confidence interval. All right. So what happens next? Once approved by the US FDA, a generic product is assigned a therapeutic rating and listed in the approved drug products with therapeutic equivalence evaluation book, also known as the Orange Book. The reason behind, its naming of Orange Book, they had it in 1980, during the time of Halloween, so they call it Orange Book, and that's why we have an Orange Book. So for a medication to be interchangeable, for a generic medication to be interchangeable, it has to be AB rated for orally administered drug, A rated or AB rated. So if it's A rated or AB rated, that means it's bioequivalent and falls, within the range set by the US FDA. If it does not, it wouldn't be AB rated. AA or AB for orally administered medication, AN for solutions and powders for aerosolization, AO for the injectable oil solutions, AB for injectable aqueous solutions, and AT for topical products. So if the generic product is AB rated, AA rated or AB rated, AN rated, AO rated, AB rated, or AT rated, that means it can be substituted or interchanged with the brand medication. And it would be approved for substitution. All right. So generic drugs are not considered therapeutically equivalent if they meet one of the below conditions. Actual or potential bioequivalence problems have not been resolved by the adequate evidence of bioequivalence, and we have witnessed a case with the Wellbutrin XL for Teva Pharmaceuticals that was relegated to BX-rated medication and eventually not to become therapeutically interchangeable. The quality standards are not inadequate, insufficient evidence to determine therapeutic equivalence, and the drug products are currently under regulatory reviews. So let's move to the beef. Let's move to what we care about here, which is the outcome of the scientific meeting. So we invited multiple stakeholders. We invited the head of the Biostatistics and Bioequivalence Department at the Saudi Food and Drug Authority. And also we invited the manager of the pharmaceutical supply at the Ministry of Interior Medical Services. We did also invite the head of the Pharmacovigilance and Bioequivalence Department, one of the largest local generic drug manufacturers, to represent the industry, and we invited the purchasing and supply chain manager at the Center of Spending Efficiency, which was recently formed according to Vision 2030, that they want to be more efficient at spending and improve the outcome, either therapeutic or market outcome. So we invited that person who holds different workshops with different stakeholders to advise them to spend more efficiently. All right. Also, we invited the Director General of the Saudi Patient Safety Center at the Ministry of Health, who is a surgeon and a practicing physician, is also responsible for the patient safety in the Kingdom of Saudi Arabia. We also invited, a big shot here, we invited the Acting Chief Executive Officer of the National Unified Procurement Company of Medical Supply, also known as NIPCO. As you may know, just recently, no governmental hospital or institution can buy any drug or medical supply alone. It needs to go through NIPCO. So NIPCO holds a huge share of the market. And any change in tendering, any change in the process can bring a medication out or in the market. All right. So how did we generate the data? The meeting was structured as a group interview. So everyone can have a say on addressing every single point that would be raised by the moderator, which was me, right? It was moderated by one of the Saudi discussion group, AABS, Clinical Trials and Regulatory Affairs Focus Group, which consists of 13 members from regulatory, Saudi FDA, from the Ministry of Health, from a health institution, from academia, as well as from the industry. It lasted for about 2.5 hours and was audio recorded and transcribed into verbatim after we took the permission of the participants for that invited. The text was reviewed and analyzed by 6 members of the focus group. So what guide is used for generic drug substitution in the Kingdom of Saudi Arabia? This is the first question we asked our participants. And for example, several countries have developed local references or guidelines for generic substitution. As an example, the US FDA used the Orange Book for interchangeability between brand and generic. The Australian Schedule of Pharmaceutical Benefits includes all medications that can be interchanged, and they rate them A rating if the generic medication is bioequivalent to the ROD or reference listed drug, and any medication or any generic medication can be substituted if it has the same rating with a brand or generic. So if we have a generic and we want to interchange it to another generic, the other generic has to be A rated as well. The Australian guidelines also rate some medication with a B rating. That means that the generic medication is bioequivalent to the ROD, but it's not bioequivalent to other generic medications. Or there's no data to actually prove it's bioequivalent to other generic medication. The Royal Dutch Pharmacists Association, Netherlands guidelines for generic substitution for community pharmacists, they have their own guidelines to encourage pharmacists to exercise some caution when they actually substitute or interchange some patients, especially patients who are on narrow therapeutic index drugs, such as cyclosporin or digoxin, or some medication in which bioequivalence is not sufficient to establish bioequivalency, such as inhaled products like fluticasone or medication that acts locally like methamphetamine. Also, they have certain patient-related factors. For example, the size, the color of the package of the generic medication for patients with mental illness should be taken into consideration whenever they interchange brand to a generic medication or whenever the generic substitution is warranted. All right, what guide is used also? We continue with the same theme. And in Saudi Arabia, for example, all registered medications are listed in the Saudi National Formulary, also known as SNF, and can be accessed through the Saudi FDA website. However, it does not include any information about the bioequivalence of generic medications. This reference does not, as I said, include any information about the bioequivalence of therapeutic interchangeability. In May 2017, however, the Saudi FDA has launched a new online service known as We Can Attempt, or We Care About You, to the public, whereby a medication can be searched using the proprietary name or generic name of the drug to look for registered alternatives that are evaluated by the Saudi FDA for their bioequivalence. So all medications that are available in that application, here you go, and they're registered there, are actually evaluated by the Saudi FDA for their bioequivalence. And if they are actually withdrawn from the market for bioequivalence issue, then a notification will be shown in that application to inform the public that there are some bioequivalence issue and there is a suspicion of that product in the market. This can be downloaded on a smartphone, iOS or Android. Also, it enables any healthcare provider to report any issue with therapeutic equivalency to the Saudi FDA. And that actually made it easier for Saudi FDA to establish a better pharmacovigilance system. They're also known in Arabic at-tayaqqul ad-dawa'i. All right. So here you go. There was an article that was published in 2013, a white paper, and it talked about, is there a need for a formulary of clinically interchangeable medicines to guide generic substitution in Saudi Arabia? And guess who were their authors? The current CEO of the Saudi FDA. So we're not joking here. I know the guy. He means business. When he says something, trust me, you agree or disagree with him. When he says something, he was without caring about anyone. And he means business, and he's an expert in patient safety. So I think, does he care about the generic manufacturers? I think he cares about patient safety more. And those who know him, can attest to that. All right. So what guide is used for generic drug substitution in the kingdom right now? Same theme. The participants agreed that so far there is no guidance or national formulary for generic substitution. The participants have also expressed some frustration over the fact that there is no national unified list of non-therapeutic index drugs. For example, each hospital in different sector has their own list of NTIDs, which is the non-therapeutic index drugs, which makes it really hard for clinicians when they do substitution, generic substitution, or interchangeability between different products. Also, interestingly, however, the Saudi FDA representative stated that the Saudi FDA is working on developing a new reference that may not look like the US FDA Orange Book, but will be designed in a way that suits the needs of the Saudi healthcare system. And just a month ago, I had another meeting, or we held another meeting at the Saudi FDA, and they were talking about the same issue. So I think there is something being prepared that will be launched. I don't know when, but I'm sure there is something being cooked in their corridors. All right. Were there any issues of therapeutic inequivalency in the past? Very good. The recalls of generic drugs due to failure to demonstrate bioequivalence to RLDs is not uncommon. And our experts in the US FDA recall the generic scandals between 1984 to 1989, when some issues, ethical issues with some employees at the US FDA happened, resulting in the Generic Drug Enforcement Act, I think in 1989. And resulting in cracking down on a lot of generics. And they withdrew 2,500 samples, and they tested them for bioequivalence. Fortunately, however, only less than 1% of them were shown to be inequivalent. And the vast majority were shown to be bioequivalent. However, what do you think the impact of that in the public? These recalls have a negative impact on the public confidence of the quality of generic products. Same thing applies in the Saudi market. We are a society who voraciously utilizes social media. And for example, look, I'm a health outcome researcher, and I think generic medication bring cost saving. But when you talk about a clinician, even a clinical pharmacist, and a lot of them are active in social media, they actually fan the flames of doubts among public that generic medications are not working. In Arabic, the cheap doesn't work. Okay? So, following the generic drug scandal, a Gallup poll or survey has shown that 51% of 1,009 consumers who were surveyed reported their fear that generic drugs were not manufactured to the same standards that brand medications are. Which actually calls into question, and this was actually voiced by some participants and some attendees at that meeting. Some of them told me, and they were CEOs of certain hospitals, we don't give our relatively generic medication that we take from the hospital. So they told me, what is the value? Even if the generic medication is cheap and will bring cost saving to the hospital, I don't trust it. That's between me and them, and probably some of my Saudi colleagues will attest to that. So there's a problem. And we need a formulary, and we need something to prove that generic medications are working. The generic medication can bring cost saving. All right. In Saudi Arabia, several generic products were withdrawn from the market over the past few years, especially after the new CEO took power. This has actually happened because we had better pharmacovigilance system. You can download Bioequivalence or We Care About You and inform about any suspicion of therapeutic inequivalence to the Saudi FDA. And once they take it, our colleagues at Saudi FDA will investigate and will verify that. And the public confidence actually was actually raised or boosted because they think, or they actually attested or witnessed that every single problem the Saudi FDA acts. So they became more active in reporting any issues with generic medications. So the rate of generic drugs withdrawal has noticed an increase lately, or at least became more public over social media, and this is not good about the public confidence of generic medications. And this is not good for actually patients who don't have any option but to take the generic medication. Therefore, a formulary might be necessary. This can be attributable to the improved post-marketing surveillance, more diverse and effective communication channels, and enhanced confidence among public healthcare providers, and the value of reporting in case of suspected therapeutic inequivalency. And who were the winner there? Some brand manufacturers. We're very happy about that. See, we have the quality, basically cheap medications, and that's what happened. As I told you, I'm an outcome researcher, I am not an industry guy. So this is a problem that we need to investigate, and that's why in our group we believe having a formulary will assist or boost the public confidence in generic medication. So how did these incidents impact the public health? The extent to which those recalled generic drugs have affected the public health in Saudi Arabia is unclear due to the paucity or dearth of data on that matter. However, there was a white paper about 2 or 1 recalled antiplatelet that, shocked the market in Saudi Arabia and UAE or United Arab Emirates because this medication was instrumental and life-saving. So patients became skeptical about the value of generic medications. However, multiple studies have highlighted the negative impact of generic substitution in some instances in public health. But when you actually, since I really care about the propensity score matching and controlling for different covariates, these studies, when they control for different covariates, such as the age, the comorbidity, the number of hospital visits, etc., the generic medication did not raise the risk of hospitalization adverse events. And by the way, even if you switch a patient from a generic to a brand, a medication with non-therapeutic index, you would expect the same issue to happen, and this was actually shown in different systematic reviews. Poor clinical outcomes were also observed in some studies, investigated that of switching from brand to generic of psychotropic medication. But as I said before, these are non-therapeutic index medications. So I think many of you remember the incident of bupropion hydrochloride. There was a PhD student at that time, and Wellbutrin XL is widely prescribed, especially among elderly, since actually it has a reduced risk of sexual dysfunction, so it being consumed a lot, and it improves the patient convenience, it's taken only once daily. But there was an issue. In 2007, 78 patients reported to the US FDA that there was a problem with their medication. That once they were switched from a brand to generic, their depression came back to them and was reported in the Physical Times Journal as an article. However, the US FDA did an investigation and found that the Cmax and AUC still falls within the acceptable module. But in 2013, the US FDA acted differently after the additional investigation, leading them to relegate the status or the rating of Wellbutrin XL to be X-rated instead of AB-rated. So right now, Wellbutrin from Teva, I don't know if anything has changed on and our experts here in the US FDA can inform us about it. It's not therapeutically changing. How did these incidents, again, the same theme? Some participants raised the issue of engaging the patient, and this was raised by the head of the patient safety and the Ministry of Health, engaging the patient in the generic substitute decision. And this was actually discussed in some literature. We talk about patient-centered care. If we don't convince the patient about the value of generic medication, even if we switch to a cheaper generic or cheaper medication, this may not result in good clinical outcome, leading to higher hospitalization, more adverse events, simply because the patient is not adherent to that medication, especially when you talk about medication with non-therapeutic index. So this was discussed in the literature, especially in the case of mandatory switching. Like in our case right now, we have economic transformation in which we want to spend more efficiently than before, so generic will be a must. The availability of the Orange Book or a similar reference may help in providing different therapeutically equivalent options for the prescribers and patients to choose from an enhanced constructive patient-centered communication. This was voiced by some participants in the meeting. So, will the rating of different generic drugs based on their therapeutic equivalency affect their prices? We'll see. The generic substitution has resulted in significant cost saving across different healthcare systems. This was actually proven in different studies. However, some studies suggest that economic savings are not guaranteed. In a study that reviewed some actually systematic review, from 1974 to 2014 showed that not all economic factors were ensured, or not all economic saving were ensured when switching was rented or reformed between brand to generic. But however, this study forgot to control for different variables. Also, it's my personal belief, I don't think all generics are the same. I think generics are valuable with their quality. This is my personal belief. I might be wrong, I might be right. But this actually was proven, at least in our market. Okay? 3 slides more. Okay? So, a cheaper generic, as suggested in some studies, does not necessarily mean a more cost-effective treatment option. If the patient is not adherent to this option, then you're not going to have a better clinical outcomes. Most participants have suggested that any future national guidelines or reference should incorporate cost-effectiveness evaluation as one of the criteria that are used to rate any generic drug. And this was voiced particularly by the CEO of NIPCO. He said that cost effectiveness should be incorporated to prove the value of some generic medication when generic substitution. So honestly, we're still living in limbo. We don't know exactly what's going to happen. But if this is the case, it will create some market access issues for some generic manufacturers. Well, the rating of different generic drugs as a central theme, the Orange Book does not actually rate the medication or does not impact their process because they're rated basically on their bioequivalence. However, they give an incentive to some generic manufacturers to ensure high criteria in GMP to ensure eventually better safety and efficacy for the patients. A generic version of the same branded drug in the United States has a significantly different average wholesale price in the Red Book. In Saudi Arabia, public prices are strictly regulated by the Saudi FDA. Any medication to be registered and launched in the market has to be priced first by a pricing committee within the Saudi FDA. So this is a different case in the US where the prices are left to the free market. However, the drugs prices that offered in the tendering process is starkly different and much cheaper. And here is the deal. The current procurement policy is based on prices only, so if an Orange Book is established, safety and efficacy might be included as well, because it would be a national guideline. The availability of a national reference of generic substitution may help policymakers and purchasers in choosing generic drugs with high quality and safety. If generic drugs were evaluated based on their cost effectiveness, they may receive favorable prices according to some participants. Finally, the Saudi healthcare system is going through a huge transformation. Right now, the Ministry of Health will not assume any rule in healthcare provision and will assume a rule of reimbursement and regulator. It is expected that the private health insurance will play a greater role in the Saudi healthcare system, and the availability of a national reference of the clinically interchangeable drug is important for that regard. Thank you so much. And the use of DSR is only an example that can be benefited from, but there are other examples that also can be that we can benefit from establishing national guidelines. Thank you so much, and I'll listen.
Thank you, Dr. Yazid. Actually, interesting. It's a hot topic. No question?
Yes. Sorry that I jump into the discussion before giving you the chance to ask a question. I really enjoyed your presentation in particular, and Adidas as well. If we start, I would very much like, if we start the discussion of the data and information you gave us, we will not end this discussion before coffee break if we shift it to 9 o'clock at night. Therefore, I would suggest that we concentrate our discussion on the headline of the session. We are here to discuss the reference product in BE studies. And therefore, I would like to come back to the question which has been asked just after the first presentation, and just ask you to keep in mind the general concept, what we are talking about. And we are talking with the regulatory authorities. They have a particular point of view which we should respect. They should also respect the concern to certain decisions from the company side. So what are the cornerstones? The first cornerstone is you should select a reference product which is based on a full clinical documentation. That is the rule worldwide. This is the basis. because due to bioequivalence assessment, you bridge to this particular documentation, and everybody considers that your product is therapeutically equivalent to the reference product. That is the basis. And then a very interesting question has been asked after Attila's presentation. What about post-marketing situation? And immediately came into my mind, all the products on the market, they change. They are modified. And if you look into the European guidelines, it is said if there is a variation of a generic product, after the variation, from a scientific point of view, I would say they should compare the product before variation with the product after variation. However, the European guideline says something different. You have to compare it again with the innovator. And the idea behind is to make sure that the products on the market are equivalent and therapeutically exchangeable. However, and that is what I have to say to our scientific colleagues on the regulatory side, the reference product can be changed in the meantime. And even if the generic company does its best to make sure that the product before the variation change and after is identical, because sometimes it's not their wish to change it, but they need to do it because an excipient is no more available, because the company got bankrupt, etc., etc. All these issues which you all know. And therefore this is very important, this is very difficult. And I know from Saudi Arabia, I heard, and I read in papers, that the Saudi FDA starts testing generics on the market and compare it with the reference product. But probably they do not have in mind that the reference product can be changed. I know a case where I am sure that the product which they selected is not equivalent to the product which has been used in the bioequivalence study by the company and which was accepted. So this is an issue where we have to find a solution, and I really ask the authorities also to be open-minded to these changes, because otherwise it's a nightmare. So that's what I wanted to say, to focus the question on the bioequivalent, on the reference product and bioequivalence studies, and now we have 10 minutes time for discussion, because then we have to continue.
May I have one question?
Sam Abdurrahman, with academia German. Again, I am from academia Germany, not from the engineering region now. I speak as a scientific person. What the Saudi Arabia regulatory now is taking generic drugs from the market and to bioequivalence study is not regulatory and scientifically not rational at all. I say why. According to the basic principle of the bioequivalence study, as you know, the two-side test.
Clarify, I do represent the Saudi FDA. I just represent myself.
Okay, that's fantastic. That's fantastic. That means I hope that we have all of us here open mind and discuss from the scientific background. That you know that is a 90% confidence interval. That means you have 90% confidence interval. That means 1 of 5 studies by luck can be failed. Suppose that's the one which Saudi Arabia takes and conducted. I cannot judge that according to dissolution test or according to bioequivalence study. You have at least to do bioequivalence study to be judged. This is the product scale. The third one. Besides what Professor Henning, my professor by the way, is telling before, that's the reference. The references. This is not rational at all. Scientifically and regulatory. And as you know, 1 minute please again. As you know, also the principle says the in vivo study overcome the dissolution in vitro. You cannot take products from the market and make dissolution test and say this is not equivalent.
If I may respond to your question, sir.
As well as
but if I may respond to your question, the Saudi FDA does not actually take action unless there are reports. So there are reports of therapeutic failure, and this is concerning to all healthcare providers, they'll take action. So I think this is legitimate from their side, to be honest, to take action whenever there is a therapeutic failure. And if actually proven to be inequivalent, they have the right to take it from that market. Patient safety is our utmost priority. So I understand. Well, this is my opinion, and you're entitled to your opinion.
I just wanted to make a comment to what Dr. Bloom said. For the US FDA, when you have a product which is on the market and at post-approval, it's very true what Dr. Bloom said. We ask for comparison against the approved product. And so it's not against the original reference, but against the approved product. So if you're making changes to your own product, then you will do a BE study comparing to the approved product and the revised formulation. And sometimes it happens that you may be coming back into the market after a long time and you don't really have your original product, then what are you going to do about it? And in that case, it would be like, sorry, you will have to go and start a new BE study against the reference product. And then in that case, if we are asking for a fasting and a fed, you will have to do both when you revise the formulation. But if you have your original, sometimes just the fasting is enough. So just wanted to clarify here.
Nilufer, you know that I sometimes congratulate authorities and sometimes I criticize them. In this particular situation, I criticize the European approach because I think the American approach is much better to ask for the comparison before the change and after the change, because it's not in your hand what happened in the meantime with the reference product. However, it is the regulators' responsibility to do their very best to make sure that with all the minor changes of the reference products over the years, in the total view, this is not a major change, to make sure that the product remains bioequivalent to itself. And that is sometimes not the case.
And
Can I say here, excuse me, because I'll tell you something about the EU variation guideline, which I know exactly the same as my name. There is always conditions when you have a variation. And it all depends whether a structure be minor or a major. Let's focus on the major. The major they call type 2, which is major. And always they're there in the European guidelines to say you have to provide bioequivalence study or justify its absence. Full stop. In other words, that this point is open for discussion, because as the professor said, there could be circumstances that might not be covered by every single line of guideline, and that would be impossible. And in this case, to allow to justify or otherwise to have provide bioequivalence. At the time of revision of the variation application, we usually go to our data system and to see what is the position of the reference product, what is the position of the original product of the generic before the changes. I personally have, for example, looked into the change of manufacturing process of a major product in the market. I didn't ask for bioequivalence. I asked for comparison between the dissolution of the product before the manufacturing changes and after the manufacturing changes, and hopefully to justify the not providing bioequivalence study. I was satisfied that the manufacturing process, although it was major, but at the same time it ended up with the same party. This is my own decision. Otherwise, I could have asked for bioequivalence. If the bioequivalence is to compare between the the generic before and after, and I'll show you the slide that the colleague has shown. Generic itself, sometimes they are not bioequivalent. And I raised that within the agency, because I'll tell you, when you have 100% line, and you have the 80 to 125, in one of your slides in the beginning, shown that the generic, one of the generic is 80 to 99. And it's still bioequivalent to the reference. Then the second generic is from 100 to 112. It's still bioequivalent to the originator. But how can you actually justify that the first generic is bioequivalent to the second generic? In other words, I have a slide myself. A equal B, C equal B, but A are not equal C. So it is very wide open, Professor, for the discussion, but I think for the guideline and for the mind of the authority as an assessor, we don't actually have to have every line discussed and covered. It's always left for the assessor discretion to decide which way to go, especially for these major, which I agree with you. We have to look into the whole picture before we decide.
Yeah, but I was not talking about the variation guideline. This variation guideline I'm very satisfied with, but in the bioequivalence guideline, it is said, if you come to the conclusion a bioequivalence study has to be done, then the bioequivalence guideline comes into play, and they clearly say you should compare the product after the variation with the innovator product, with the reference product, in the bioequivalence guideline. And that's what I criticize, because and that was our dialogue.
Right, and I think if I can say, not every change will need a BE study.
Yeah, that's for sure. Yeah.
So, depending upon the level of change, not every change may need a BE study, and you must just be well enough doing a dissolution. But even when you do the dissolution, the comparator is your originally approved versus the revised formulation.
Yeah. It looks to me we all agree on the basis that the assessor, the health authority would have the open mind to assess the question. Anyway, it's for the professor.
Now, after listening to Annie and the lady was asking a question, I remember very critical case was in our hand. Not always the generic side or the reference side had some problem. But the authority had some problem too. Why? Your question. The variation is a different issue, as Annie mentioned. We had a drug product for bioequivalence study. Fasting condition and the PAT condition. Here are the fasting conditions results were perfect. One of the PAT condition, AUC was okay, but Cmax failed. Why? Because the originator product in patient information leaflet was saying after the meal should they apply, should be given. We did. But we depended on the authority, they did not say. Now, let me stop here. Let me return to originator product. Originator product registered 1970 or 74. Earlier than the PET studies. Now, that we had a reference product, didn't run any PET study. But on the other hand, they have a generic product. We must follow the European guideline under the PET study and pay. And I think we should carry this point through EMA, because this is not fair. If the generic company is using a reference product, it must be followed every condition in the guideline. Otherwise, it must not be compared.
That's for sure, and the EMA people, they know my concern related to the advice that the bioequivalence study should be done under conditions as mentioned in the SMPC of the innovator product. Because with the grandfather's drugs, that came just out of the blue. Why, for example, Ambroxol should be taken after a meal? There's no scientific rationale for that. There's no tolerability improvement. There's nothing. But it is said from the 1880s or 60s, 1960s of course, that it should be taken after a meal. But there's no scientific rationale. I fully agree with that. And I think we need to finish. And just one remark, because I would like to take up one point of the two generics. Please keep in mind that in the European understanding, bioequivalence assessment does not mean interchangeability, in particular between all the generics. So that is difficult if we can organize a conference on that issue. I don't want to open this box of Pandora, but so thank you very much, the chairperson. And I would like to ask the chairperson of the next session on biosimilars to start immediately right now. And I would like to hand over the microphone to them. And please, because we have limited time, the presenters of the next session, please try to stay in 25 minutes.